Well, first of all, thank you all for your presentations today, and thank you for your promptness this time. Congratulations. I might have heard I rule with an iron fist. All right, so the good news is we have some time for some questions, and boy howdy do you guys have questions. You've been pretty quiet in questions today, but now we got a lot of questions for the liposuction panel.
Remember, it's happy hour.
Yes. For Dr. Schwartz, how do you handle Derkham's disease patients, and would you use Vaser as well? And what type and have you felt that has worked the best?
I have the same approach, really. With Derkham's, the only difference would be to identify nodules and identify with the patient the nodules preoperatively, especially the ones that are bothersome, and try to get those out. And often, as was demonstrated, you need to make a little incision around those nodules if they're not easily broken up with the liposuction.
Okay. Dr. Amron, why are lipedema patients at an increased risk for a DVT?
A couple reasons. So first of all, a lot of these patients have a hypercoagulable state. If you go through and test a lot of clotting factors, factor V deficiency and this and that, and it goes past my level of knowledge. So I currently, over the last few years, prophylactically anticoagulate patients perioperatively. The second reason is a lot of these patients have fibrosis and congestion, and after the surgery, even under a surgery where they can walk that same day or the next day, they are less mobile, they've got constrictive garments on. Those constrictive garments can create areas of stasis, and those areas of stasis can set a person up for DVT formation. And so I think that the stage 3, stage 4 patients that are more complicated, have more fibrosis, do have an increased risk of DVT formation simply because of that fact.
Okay. Dr. Krochmal, do you later address the excess skin?
Sure. Hello?
Just
Yep.
keep talking. Just talk
yes.
and it'll come on.
I do. If patients really want me to go ahead and address the excess skin, then I'm happy to go and take off as much as I possibly can to give them an absolutely fantastic result. I typically wait at least 3 months before doing it. I really want that skin and scar tissue beneath the skin to really soften up before I go ahead and I do any kind of a secondary procedure. But sure, I think just by having some excess skin there, it sets you up for some additional complications like cellulitis, fungal infections, and things like that. So if I can remove excess skin, absolutely, I'll go ahead and do it.
Okay. Dr. Shapira, with a history of cellulitis, can a person ever be a surgery candidate?
Yes.
Okay. Just keep talking and it'll go.
Yes, I don't see why not.
Okay. Anything that they need to be concerned, that they need to do to prepare for surgery?
Well, I just want to make sure probably they don't, what the etiology of the cellulitis, if it's just a small trauma to the skin resulting with infection, it's one thing. If it's associated with the peripheral venous disease, I may be more aggressive in trying to treat it. Although we heard earlier today, I think often people are too aggressive or unnecessarily aggressive in treating venous insufficiency. So I'll be probably more careful investigating the etiology before I proceed, but it's not a reason not to do it. I just wait for complete healing.
Okay. And the next question is for each of you, but we'll start with you, Dr. Shapira. Do you have BMI limitations to do liposuction?
No.
Okay. Does anyone else have any BMI limitations?
No, I think the nature of lipedema is such that you have to put those aside, and there are different considerations, different volumes, a lot of different criteria when treating patients with lipedema.
I can't add anything more to what they said. I completely agree.
I agree. I think BMI is an old, archaic way of measuring obesity, and it really doesn't belong in treating lipedema patients.
Okay.
I want to add one comment. I really think that using the BMI as a criterion whether the patient accepted to surgery or not, I think it's wrong. I think many patients with the lipedema, they get caught in a vicious cycle. The high weight, especially between the legs, the thighs, and the knees, they make them immobile. When they're immobile, they cannot lose weight. When they cannot lose weight, they get less immobile, etc., etc., etc. I would like the patient to try to lose weight because it's part of the motivation that takes them into the surgery, and they will not. I don't think the surgery by itself is the answer for everything, but I would like to see some change in lifestyle, in the motivation. But when it comes to surgery, I will do it with any BMI, because I think by surgery, you can stop this vicious cycle, can stop it, and enable the patient to start to move better, to be more active, and to start to lose weight. So that's basically our philosophy.
Okay. Dr. Schwartz, does having a C-section interfere with the abdominal liposuction that you described earlier?
Did you say having a C-section?
C-section, yes.
No, that does not interfere. That scar is low, and it doesn't interfere with liposuction or abdominoplasty.
Okay. Dr. Krochmal, can removal of lipedema fat in the legs and arms increase the fat in the liver?
Oh, that's a really good question. Yeah. I'll probably kind of defer to some of my PhD colleagues on that one. I'm not terribly sure. Yeah, I just have a metal straw with a vacuum. Yeah, that's my specialty. Yeah, I'm not sure about that one. Does anybody else maybe know the answer to that one? Want to weigh in?
Good question.
Yeah, I don't think we know it. I think just in general, doing large volume liposuction in general in patients doesn't really change around the lipid profile significantly, so I don't know if it would really be any different in lipedema patients. That's a really good question. Maybe I'll be invited back next year and I'll have an answer for you.
Yes, okay. Well, Dr. Krochmal, a follow-up question. Which technique are you using in your high volume liposuctions? Which devices are you using? I
typically try to do dual liposuction if I possibly can. And the facility that I operate in only has one power-assisted liposuction set, so I use the power-assisted liposuction. And my assistant just uses regular liposuction. So we use tumescent, so we overly tumesce the area. We use a wet technique to really put in as much of tumescent fluid as we possibly can. On one side, I'll be doing power assisted. On the other side, we'll be doing just regular liposuction. I wish we had two power assisteds, more for my colleague, but we don't use energy devices.
Okay. I believe this question, well, I'll ask the question to anyone who's doing brachioplasty. The question is how are the lymphatics preserved during a brachioplasty?
There are multiple methods to doing a brachioplasty. I trained with Joe Hunstad, and he was a big fan of doing liposuction first. So what I do for my brachioplasties is I mark the area of likely skin excision and actually do aggressive liposuction in that area to wipe out all the fat. Liposuction, at least in the upper extremity and in the thighs when I'm doing the thigh plasties, it removes the fat, but it does a really nice job of preserving the major blood vessels, the nerves, and the lymphatics. So by wiping out all the fat, it kind of perfectly preserves this whole lattice work of the important vital structures underneath the skin. And then afterwards, I'll go ahead and only remove the skin and literally just peel the skin off of the arm. And when you do that, you see the perfect lattice work of all those vital structures underneath. So at least the way that I do it, I don't think that very many of the lymphatics are actually disrupted doing this particular technique.
Okay.
I would just add that we're also not in the axilla. It looks like we're in the axilla, but we're making an incision, or even in an extended brachioplasty where you extend it down into the lateral thoracic area. You're just superficially peeling the skin, so you're not affecting the multiple lymph nodes in the axilla.
Okay. Next question, and we'll start with Dr. Shapira on this one, is the question's for everyone. Have any of the surgeons had luck with insurance? We'll start with you, Dr. Shapira. Have you had any luck with insurance? Insurance paying for liposuction?
That's a heavy subject.
Yes, it is.
Well, yes, the answer is again yes. I would say, the top of my head, when we pay, well, when patients that are coming and most of them really cannot afford to pay all this, this is a huge expense. And I basically think that I don't think patients should dip into their 401k or pension plan in order to survive and go through something that, for me, I think it's a basic commitment, obligation of the society. So we really spend a lot of energy in trying to do that. I would say that patients that we start the process, and that's the majority of the patients, I think probably are successful in about, I would say, 85% of the patients who get reimbursed by the insurance company. It's not easy. Rarely, there are a few steps. First, we apply with the peer certification, and that's a lot of paperwork, a lot of letter of medical necessity, documentation, you name it. Very few get approved, and the reason that there's no CPT code, no code for surgery of lipedema. So the codes that we are using are codes that we borrow from other areas, and which is, doesn't matter the number, but they come up automatically. It's plastic or improvement of appearance, not for lipedema. And they automatically get rejected by the computer. So then we have to go through peer-to-peer. That we get approval by the peer-to-peer a few times, but usually it's not authorized to do it, the medical director. So then we're going to the first level appeal. Maybe we get another 25% approval. Then we go to a second level appeal, which is a whole committee in the insurance company. Maybe you get another 20%. And if they reject it, then it goes to external appeal. And that gives us a few more success. So I would say, but it's a lengthy procedure. It can take easy half a year to 9 months, a lot of paperwork, a lot of headache, a lot of frustration. The reimbursement issue is completely different. I will not go into that, but that's another issue.
Same question. We've had some luck with patients getting reimbursed, and we provide a letter of medical necessity. We try to get pre-authorization of sorts, and that really doesn't matter to insurance companies. They'll authorize something and then deny it 9 times out of 10. But if you have a letter of medical necessity and we provide operative reports and help with billing afterwards, we don't do billing ourselves, but help with that. And you heard from the attorney today, and there's also an attorney who's here at the meeting. I'm sorry, I don't remember her name, but she's representing a few patients with United Healthcare now, and there's also a class action suit against Blue Cross right now. So things may be improving on the insurance front.
Yeah, I've had kind of a similar experience. I don't know how much of it is luck with the insurance companies versus just a simple war of attrition. And so my patients that have had success getting coverage have just really been filling out appeal after appeal and even going to the state boards. And so we'll help out when we can.
Yeah, not that dissimilar. That I have extensive experience dealing with this. I've been hoping over the years I've been involved with lipedema, things would have changed, and it still is a very frustrating place for all of us. Certainly we have our own process. I've got a whole team working on it and substantiating it. And I think unless you're going to do multiple procedures and use coexisting diagnoses, it's really a challenge. In my practice, probably 5% to maybe 10% at most eventually get it covered. And the different carriers are each different. Blue Cross and Blue Shield, my experience has been the worst. I'm happy to report that Karen Herbst, and Stanley Rocks and Stanford are involved in a class action case against Blue Cross Blue Shield. So hopefully that'll set the tone for things and things will start to change.
Okay. And our final question, which is addressed to all of you, we'll start with Dr. Amron, is does the fat return after liposuction, and how lasting are the effects?
Yeah,
Loaded
important. Yeah, important and good question. I have a lot of experience. I've done over 2,000 lipedema patients. So I'll try to be quick with this, Cheyenne, but you go back to what is causing lipedema, right? So lipedema is not just a fat condition. It's a systemic condition that goes on, and the primary thing is the leakiness of lymphatics, where fluid is moving out. So why should liposuction just completely just take care of everything? Well, it's the biggest life-changing thing, that's for sure. In my experience, patients fall into different categories after the surgery. Most people, it just doesn't come back as long as they're paying attention to their preventative measures, dietary strategies, lifestyle things, compression stuff in those patients that continue to swell. But there is a very small percentage of patients, and I've had probably less than 1%, so I've had a few patients where it has come back to varying degrees. And those patients all had the commonality of very aggressive lymphorrhea, movement of fluid out. So that's a very important thing to pay attention to. Both understand that before the surgery, those patients should be bandaged. I've now changed my post-surgical compression therapy and bandaging more patients, but also paying attention to it. If patients are swelling after the surgery, that signifies the potential recurrence of that lymphorrhea and that deposition of stem cells in that layer of fat. So using the word cure is a very potent word. It's probably close to a cure, but I still don't think we can use that word cure. Potentially, in smaller percentage of patients, it can come back.
Yeah, I agree. I don't think that we can use the cure quite yet. And for anything that is progressive in terms of disease, I kind of liken it to cutting your fingernails back. I mean, just because your fingernails are getting long, if you cut them back, sure, they might grow again, but the opportunity to function better with shorter fingernails, I think, is worth it. So I think being aggressive with liposuction for patients that have aggressive lipedema, wiping it out as much as you can possibly or do to save them from some future surgeries, I think is going to be best. And at the same time, in addition to just wiping out the fat, I'm also inducing some scarring and inducing some fibrosis. So hopefully by inducing some internal scarring, which I almost consider to be like an internal compression garment, would prevent some extra edema from getting out into the tissues and preventing some of the fat growth just by having that extra pressure and scar tissue there.
I don't have a lot to add. I agree with both of the doctors. I agree that, first of all, we can't remove every diseased fat cell. You have to leave a layer of fat. Otherwise, you'd have really severe contour deformities. You have skin sticking to muscle lining, and we don't want that. So it's impossible to remove all the diseased fat. However, I agree that we are creating some scar tissue, and as Dr. Krochmal said, doing revision liposuction surgery is really tough. It's 10 times more work trying to get through seemingly soft fat, but in actuality can be cement when you try to even infiltrate fluid into it. So one interesting thing is a lot of our patients have reported that they feel their breasts have enlarged after having liposuction for lipedema. I don't think, I've talked to some people about that. There's no data on that. It's controversial as to whether it recurs in other areas or comes on more exuberantly in other areas. I don't think anyone knows the answer to that either, but these things are all being looked into.
Well, I think the jury is still out about this subject. The data that we have, I believe are going up to 10 or 12 years that patients feel improvement. But I don't think we don't have really data to document that the problem has resolved. What I do know, however, that if the patient really keep a healthy lifestyle, and if the operation triggers resumption of mobility, more activity, the pain in the knees get relieved, they can resume life activity, and if they keep good diet, and very important to keep stay on anti-inflammatory diet and good lifestyle, I think all that will minimize the chance of recurrence. I don't think at this point we can say anything else, but I think there's a lot of hope for that.
Okay.
Can I add one thing to it?
Of course, Dr. Abram.
So one of the patients that are out there, a patient by Yasmin that spoke here before, who had amazing results, that poster type of patient out there. After many years, she had some stress, hormonal changes, and developed a little bit of swelling in certain areas that were completely clear of fat around her calf area and the medial thigh area. So a few months ago, I went back in, even on that patient, to go back and do a little bit of touch-up in an area. So it is an example that even in a patient like that, without the right lifestyle consistency, it potentially can come back. And that's why we cannot use that word cure, long-term improvement.
All right. Well, thank you all so much for your participation and all the education today.